Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Lilly.
Good afternoon, everybody. We are here today to talk about the Alzheimer's disease precision diagnostics. This is part 2 on cerebrospinal fluid biomarkers. I'm Dr. Ana Pereira. I'm a cognitive neurologist and neuroscientist at Mount Sinai School of Medicine. And we're excited to have you all here. This program has been supported by an educational grant from Eli Lilly. We'll talk about cerebrospinal fluid biomarker testing for diagnosis and when to use it and a lot of the nuances of this. We have had a lecture on amyloid PET, and in August, Dr. Suzanne Schindler will be giving a talk on plasma blood biomarkers for Alzheimer's disease. So, as you know, Alzheimer's disease, it's in a continuum. You can have cognitive unimpaired patients who are normal. Then you have an MCI, mild cognitive impairment, in which patients have some domain of cognitive impairment, but still can function in daily life, activities of daily living. And you have then dementia, in which you have more than one domains affected, and it impairs activity of daily living, such as paying bills, taking care of medication, and so on and so forth. And there are multiple stages. You have mild, moderate, and severe. And those are syndromes, and there are multiple causes for those syndromes. The most common one, as you know, is Alzheimer's disease, AD. The most typical Alzheimer's phenotype is the amnestic syndrome. So patients present with memory loss, partner will come, oh, they're repeating questions, forgetting conversations, forgetting appointments, things like that. But there are other atypical forms of Alzheimer's. They also have amyloid and tau pathology, but in different brain areas. So in the amnestic form, it's mostly the hippocampus affected, the middle temporal lobe, while in atypical form, we can have this logopenic variant primary progressive aphasia. So patients start off with a language disorder, trouble finding words, vitreating words, trouble repetition, and a lot of phonemic processing problems. Where the posterior cortical atrophy, this disease starts more on the back of the brain, in the parietal occipital. So patients start, instead of memory loss as the presenting symptom, they can start off more with the visual spatial. I have a patient, for example, who couldn't park his boat. That was his first presentation. Or visual field cut, but the tau starts more in the back of the brain. We can also have cortical basal syndrome or frontal Alzheimer's. Patients are more disinhibited or apathy, which can be confusing sometimes with behavior variant FTD, and that's why biomarkers are also very important in differentiating those syndromes. And Alzheimer's is not the only type of degeneration, it's the most common one, but you can also have frontotemporal degeneration, Lewy body disease, vascular disease, and other underlying pathologies, such as alpha-synuclein accumulation, which is typical for Lewy body disease, or TDP-43 for late known tauopathies, like PSP or corticobasal degeneration, vascular pathology. So you really have to understand and put all the data together, the history, the neurological exam, the cognitive data, and now we have biomarkers really integrating all those data, imaging, and molecular data to come up with the best diagnosis and best care for your patient. So as I pointed out, last section was on amyloid PET, which is being used clinically a lot, especially now with the anti-amyloid therapies for monitoring, etc. We'll talk today about CSF, and the talk on August 4th is going to focus on plasma biomarkers. As you know, Alzheimer's has become a lot more as a biological entity defined by those ATN, amyloid, tau, neurodegeneration. Decades ago, people would put everything under this term. So now we are much more specific biologically and molecularly, just like oncology, a parallel, have a molecular data to support the diagnosis. So in On the A beta deposition, you usually have low CSF beta 42, low CSF 42 to 40 ratio. We're going to talk a little bit about those ratios. Positive amyloid PET and a high blood phospho-tau 217. And the T for the tau, pathological tau, we can have high phospho-tau in the CSF, those are soluble species, or the positive tau PET, which is insoluble species, and high plasma phospho-tau 217 by 42 ratio. And the end for neurodegeneration, structural MRI have particular patterns of atrophy, FDG PET to look into metabolism in the brain, and high CSF total tau. So this concept of ATN that has been incorporating more and more biomarkers in terms of our diagnostic criteria. So let's delve a little bit more into the cerebral fluid AT biomarkers. So what are the two major gold standards? One is the amyloid PET and the other is the CSF biomarker measurements. So what are the advantages of each of them? The amyloid PET can visualize the plaque-associated A-beta fibrils. So those are the insoluble plaques that have accumulated in the brain. The advantage is that it can give you a load and distribution of amyloid. You can report it visually as positive and negative. And as for those who attended the meeting on amyloid PET, you can also do more quantitative analysis with programs the radiologists have to give the centiloid amount of amyloid accumulation in the brain. And it's particularly helpful in patients undergoing anti-amyloid therapy so that you can have the baseline and after therapy, how much of the amyloid has been removed from the brain. It represents amyloid pathology that has accumulated over the years. As you know, amyloid started accumulating over a decade before symptom onset. It's highly accurate in patients with moderate to frequent amyloid plaques. It can be costly and uses some amount of radiation that is FDA approved. And I think it's particularly helpful to monitor anti-amyloid therapy before and after therapy. I had a patient that was on anti-amyloid therapy, started off with 98 of SUVR, and this week had the repeat PET scan, and it's now 0. So basically, entirely removed the amyloid from the brain. How about the CSF biomarker measurements? It measures the soluble amyloid, and actually, if you look into the trajectory of amyloid biomarkers, the soluble species start accumulating even earlier than the insoluble PET species, so it can be more sensitive at the very early stages. It can provide quantitative information about several biomarkers, and I think that's the beauty and the major use of CSF biomarkers. You can look into multiple markers, not just amyloid. We're going to go over it in a few slides. You can look at tau, synuclein, and immune markers, etc. It's reported as biomarker concentrations or ratios. It provides dynamic pictures of pathology at the times of measurements. It has over 90% concordance with amyloid PET. However, it does not provide anatomic localization. It's less costly than the PET, but requires trained clinicians, and it has no radiation. So I think you really have to think for each patient what is the best approach individually. What are the key CSF biomarkers for Alzheimer's? Beta 42, phospho-tau 181, total tau, and you can use the ratios, especially in patients who have borderlines. The ratios can help tease this out a little bit more. 4240, beta 181 by beta 42, total tau by beta 42. We can also see some of those in this paper and another one that Suzanne Schindler and I wrote in radical neurology. So you can see here the ratios of 141, 42, total tau by 42 has better sensitivity and specificity with amyloid PET. So the ratio CSF analytes rather than a beta 42 alone is the most accurate in determining amyloid status. So CSF Alzheimer's biomarkers in practice. So what is the appropriate use criteria for using it? So in patients, for example, obviously with cognitive impairments, MCI that is persistent, progressing, and unexplained, or patients with some subjective cognitive decline that is a high risk of Alzheimer's, patients with symptoms suggestive of Alzheimer's, MCI with early onsets. I usually do a lot in early onset just to rule out any other copathology like autoimmune, paraneoplastic, to have a more broad evaluation of differential diagnosis in the early onset cases. Patients meeting core clinical criteria for probable Alzheimer's with typical age of onset, patients with dominant symptoms in change in behavior, that sometimes you aren't sure if it's FTD versus Alzheimer's or when Alzheimer's is being considered. And I think very important to evaluate for other causes of cognitive impairment, especially in cases that we're not entirely sure, and you want to rule out other causes, for example, autoimmune or CGD, patients with more rapid progressive cognitive impairment, or synuclein seed amplification assay that is now available for when you think there's co-pathology with Lewy body disease, or Lewy body may be the major driver, but in particular to rule out autoimmune or paraneoplastic cases. What are inappropriate uses? Patients who are entirely normal, no suggestions, no high risk of to determine severity of patients diagnosed with Alzheimer's is not going to give you severity in patients without cognitive impairment just because they're APOE4 carriers. So what are factors in choosing where to go? Should I use the amyloid PET or CSF? So I think for patients who are, for example, candidates for anti-amyloid therapies, you could use either of them, either CSF or amyloid. However, if you want to do quantification before and after therapy to see if the amyloid is being removed, the amyloid PET is usually best for those cases. Patients who are, for example, very concerned with radiation, then CSF would be more appropriate. I think a very important one is differential diagnosis that are not all Alzheimer's conditions. If you want to look for rapidly progressive dementia, CJD or other causes, or rule out some patients have something else that is suspect autoimmune or paraneoplastic. If you want to test synuclein beside Alzheimer's biomarkers, so those are better for CSF because the amyloid PET is just measuring the amyloid. The CSF allows you to look into multiple biomarkers at the same time. For someone who has severe claustrophobia, for example, CSF is better. For patients on anticoagulation medications, the amyloid PET would be better because we don't want to increase the risk of bleeding. For patients who are very concerned about LP, usually you educate them the LP is not dangerous in well-trained hands, but if they're still reluctant, then the amyloid PET will be better. Patients who have had back surgeries, have severe lumbar depositing, CSF would be a little harder, then maybe amyloid PET would be better. So you really have to go on a case-by-case basis to see what is the best for your patient. So as I pointed out, CSF testing is most used for patients who have a wide differential diagnosis that include non-Alzheimer's causes of dementia, like rapidly progressive Alzheimer's. You want to look into inflammatory, paraneoplastic, or cases that you're suspecting other things that is not Alzheimer's as well, like Lewy body. So those are the best case for CSF to rule out many important differential diagnoses. So what are the tests that you usually use for routine laboratory studies such as cell counts, protein glucose, cell differentiation? You can test for autoimmune condition, paraneoplastic, autoantibody panels, the many autoantibody panels against autoimmune and paraneoplastic oligoclonal bands, immunoglobulin profiles. There has a suspicion of CJD clinically, myoclonals or MRI findings, such as the WI enhancement that you want to look into CJD. You can look in the prion protein. There's a prion center where you can sense yourself. The novel test for synucleinopathies is not FDA approved yet, but we're starting using those clinically, the seed amplification assays. And obviously, we test the Alzheimer's, the beta 42/40 ratios, phosphotal 181 ratios. So you can look at multiple measures and rule out a lot of things, particular cases that are suspicious for rapidly progressive, or you are unsure about the diagnosis. Those are great indications for using CSF. So what are the advantages? I think I talked about this already. Allows you to evaluate multiple potential etiologies. The disadvantages, many people think the LP is invasive, but I was just in Europe, patients do CSF very routinely in neurology clinics in Europe. I think you can learn from that. Explain the risk of headache, bleeding infection, which is very, very low in well-trained hands. And the disadvantage, it does not provide information on the regional distribution of Alzheimer's pathology. And for patients who have severe back injury, surgery, or anticoagulations, those better use other markers than the CSF. So how to address patients and see about lumbar punctures? Some people talk about lumbar puncture, they're scared. Education really explain to patients the potential risks and benefits. There is risk of bleeding, infection, and post-op headache, but in well-trained hands and centers, this risk is very mild, short duration. Actually, I've never seen any personally major complications of LP. We have an LP clinic. They do LP all day long, so they're very well trained. I explained the procedures and address questions and concerns and discuss the benefits of CSF biomarker testing. And sometimes for patients, if you explain, this is going to allow us to rule out a lot of potential other things that we're worried about. And this is the best test for us to look into multiple analytes, provide more accurate diagnosis, and rule out important conditions. I think it's very important to emphasize for us cognitive neurologists or all clinicians, we cannot stand only one test. We have to look into the history, a detailed history, cognitive exam, brain imaging, and look at the molecular data with CSF or blood or PETs is an additional piece of information that you can integrate into the whole clinical picture of patients for the best diagnosis. So what happens in CSF biomarker results? So you have low A beta 42 and A beta 42 40, so the ratio is low. You have high phospho-tau 81 and the phospho-tau 181 go high and A beta 42 goes low. So ultimately you're going to have a higher phospho-tau 181 to A beta 42 ratio. And you have high total tau, the ratio total tau goes high, A beta 42 goes low is the denominator, so ultimately it goes even higher total tau A beta 42 ratios. So the ratios can be helpful, particularly when results are borderline or discordant. But remember, the A beta 42 40 goes low and phospho-tau 181 goes high, total tau go high. So this is a key take-home message. So what happens when the CSF biomarkers, even when you look at the ratios and everything, goes into intermediate results? So if the patient is particularly eligible for anti-amyloid therapy, then follow-up with amyloid PET will be important. But if it's not urgent, you can follow patient clinically and do more studies in the future, such as plasma. But for those going for anti-amyloid therapy, then you can confirm with amyloid PET scans, which can give regional anatomy and further quantification. Other factors that may influence CSF biomarker results, so I won't spend too much time in this, but they can have, for example, other conditions such as lower pressure hydrocephalus that can change the dynamics of the CSF fluid. And having really a protocol in your center in terms of collection, handling, how to send out those kits to the labs, well established so that you can reduce probability in any changes there. So returning biomarker test results, what to discuss to patients? Go over the results and what they mean. So as you pointed out at the beginning of this talk, there are many causes of cognitive impairment or dementias. And the biomarker testing, along with the clinical history, MRI imaging, cognitive data can help you specify the cause. What happens if someone has cognitive impairment, but the Alzheimer's biomarkers are negative? I see that all the time. So that means it's not Alzheimer's, but you will have to go deeper in what is the underlying etiology. I just saw someone last week who had memory impairment and variable executive dysfunction, someone in the 80s, and the amyloid PET scan was negative, and he actually had some emerging Parkinsonism. We're going to do sleep study to look into biomarkers for RAM without atonia. He likely had the emerging Lewy body disease. A lot of cases are someone amnestic, amyloid negative. It could be TDP43. Late, we don't have good biomarkers for late yet. But just to bear in mind that the patient still has cognitive impairment, and we need to try to understand the underlying cause. The other very important thing is to try to also look for conditions that could be treated and it could be exacerbating the situation. Very commonly, obstructive sleep apnea patients can have some executive dysfunctioning, memory issues. So doing more sleep studies on those patients, treat sleep apnea with CPAP or others. Mood conditions, sometimes patients with severe depression and other conditions. Actually, depression and mood issues can be also the beginning of neurodegenerative conditions. But treat those mood disorders, treat things that are treatable. It's a slowly progressive disease. It's very heterogeneous, actually. I study in my lab a lot of heterogeneity where some patients progress faster, more slowly, but sometimes the exact prognosis is uncertain and we need a lot more studies and biomarkers to predict how patients are going to progress. CSF biomarkers change very slowly. So if someone has a clearly positive or clearly negative CSF, there's currently no evidence to repeat CSF within the next 1 to 3 years. So we can follow them clinically or do other kind of studies. There's no point in repeating the CSF. It's clearly positive or clearly negative. Always talk to patients about lifestyle changes, physical exercise, healthy diet, keeping socially stimulated, cognitively stimulated, control vascular risk factors, hypertension, diabetes. All those conditions can cause white matter lesions and exacerbate those situations. So a lot of behavior changes. Treat sleep apnea if it's untreated. Treat mood disorders. Treat hypothyroid. I just diagnosed last week someone with hypothyroidism. It was not a major cause, but it was exacerbating his cognitive issues. So always look into things that could be treatable. Enjoying the present with the family and loved ones and planning for the future so that the patients in the beginning stages of this can have legal and financial planning, advanced care planning. The available therapies, symptomatic treatments, as you know, the cholinesterase inhibitors, and now we have amyloid or lowering therapies for patients with MCI or mild Alzheimer's. And we need biomarkers for those therapies, CSF or PET. And there are 2 FDA-approved medications, as you know, the lecanemab and the donanemab. They very robustly remove amyloid from the brains, and it's predicted to slow progression by about 30%. You have to look into ApoE carriers to look into risk of ARIA and look for infusion reactions as well. So for eligibility for anti-amyloid therapies, we use amyloid PET and CSF biomarkers. They should be there if they approved. In terms of monitoring disease response, amyloid PET has more robust ways to do so. I think usually for patients undergoing anti-amyloid therapy, if there's no major other diagnostics consideration in terms of autoimmune, paraneoplastic, or things like that, I usually prefer doing amyloid PET so that I can check before and after therapy for response for anti-amyloid therapy. The CSF longitudinal data, they are still under evaluations. There's currently no recommendation to test repeats or how to interpret results. I think this is still ongoing. So take-home messages, CSF test is most useful in patients who have a wide differential diagnosis that include known Alzheimer's causes of dementia, like rapidly progressive, autoimmune, paraneoplastics. You want to look into synucleinopathy as well, or many other considerations you have, or infectious causes, and so on and so forth. The ratio of CSF analytes rather than A-beta 42 alone is most accurate in determining amyloid status. Individuals with positive AD test may have other conditions causing or contribute to cognitive impairments. So it's crucial to evaluate and manage other conditions as well. Someone with diagnosed with Alzheimer's may also have severe sleep apnea, and you should treat the sleep apnea as well. Always think about the treatables or hypothyroidism or mood disorders. So look at the whole picture of the patients. So CSF testing sometimes can be limited by practical issues. Some centers don't perform it routinely, But I think it always be great to have individuals well trained in LPs. For example, in our center, we have an LP clinic, and the physicians well trained that rotate whole day doing LP. So we're very, very well trained on that. And CSF results should be interpreted within the whole clinical context, as I pointed out. Look into clinical history, the imaging, the cognitive data, and besides the molecular data. So really integrate all these data sets. I would like to thank all of you again for your attention and your interest in learning about CSF biomarkers. Thank you so much.